Hello, good afternoon, everyone, and you're welcome to the ECG workshop for the 2024 Annual General and Scientific Meeting of the Ghanaian Society of Cardiology. And we'll be beginning shortly. The slides will be shared on the screen, and then we'll begin with the presentation. My name is Proficiency, and I'll be moderating this session, which will be led by Doctors Abdul Subu Yakubu and Felix Awendalgo. And so once we are ready to start, once the slides are shared, we'll begin right away. Thank you. All right, so we are ready to begin. So then Dr. Abdul Subu Yakubu is a senior specialist physician and a cardiologist at the Tamale Teaching Hospital. And he will be our main facilitator, supported by Dr. Felix Awendalgo, who's a physician specialist and cardiology fellow at the Department of Internal Medicine of the Kolebu Teaching Hospital. We'll begin by going through a few theoretical concepts, and then we'll try our hands on a few ECGs. It's going to be interactive, so I'd encourage that as many people as possible participate in this, and feel free to drop questions in the chat box and they'll be answered in due course. So thank you very much, and Dr. Yakubu, over to you.
Good evening, everyone. Thank you very much, Dr. Samoa, for the introduction. We're going to have two parts to this session. The first part would be a brief overview of basic ECG reading. And in the second part, we're going to look at some ECGs and then try to make sense out of them. We encourage that you'll send in your questions as we go along. We encourage as much participation as possible, and Dr. Felix Awendalgo will be helping me along the way. So the ECG is a recording of the electrical activity of the heart, and there's a lot of information that we can get from the ECG, okay, from conduction abnormality to ischemia to chamber enlargement, and even abnormality that are not intrinsic to the heart, like hypothermia and electrolyte abnormality. And so the importance of ACG in the workup of our patients, especially patients with cardiac pathology, cannot be overemphasized. So this diagram shows the conduction system of the heart. Usually the impulses will be generated from the sinus node. Then it will spread through the atria and then end up at the AV node. So usually there's a physiological pause at the AV node in order to allow the ventricles to adequately fill, okay, and then pump out blood. So this physiological pause is extremely important. And so conduction abnormalities at this point can have adverse effects on the function of the heart. Now, from the AV node, these impulses are conducted down special pathways, down both right and left ventricles through the bundle branches. On the left side, it divides into an anterior and a posterior fascicle, and then we have a huge right bundle that supplies there. And this electrical activity in the heart is manifest on our surface ECG as various waves that we can use to identify pathology at various stages of this conduction process. And so the P waves, because the atria are generally, P waves represent atrial activity. So because the atria are small in size, the P wave generally will be a small wave. So that will be atrial depolarization. The repolarization usually will not show on the surface ECG of the atria. And the ventricular depolarization will manifest as this large QRS complex because of the relatively large mass of the ventricle. And then ventricular, there's an isoelectric point, then ventricular, the T wave repolarization will manifest as the T wave. Okay, so basically this is what the ECG tells us, and there are various segments of the ECG that tell about various pathologies and various intervals, which we'll look at as we go along. So the standard 12 lead ECG consists of limb leads and then precordial leads. Okay. And then each of the leads views the heart from a particular viewpoint. So the 12 lead ECG, we get a lot of information for the 12 lead ECG because each of the leads views the heart from its own perspective, and so we need to integrate all the information from all the leads to be able to arrive at a diagnosis, which is why we have so many leads. Occasionally, we can have more leads. Okay, so the precordial leads, we can have more than 6 of them, we can have 7, 8, 9 in order to view, because the heart is a three-dimensional structure. So having extra leads helps us to view the heart much more completely. Now, the limb leads, we have the bipolar leads, which view it looks at the difference between the standard limb leads. So, for example, lead 1 will be looking at voltages from the left arm to the right, from the right arm to the left arm. Lead 2 from the right arm to the left leg, and then lead 3 from the left arm to the left leg. Okay, and then we have the augmented limb leads, which looks at the voltages traveling in the direction or away from that limb relative to the other leads. And we say it's augmented because it is magnified in order for the signal to be perceptible. Now, the leads are placed on the precordium as various intercostal spaces. Okay, and often when we are reading the ECG, we take it for granted that the ECG has been recorded properly. The person making the recording is as important as the one reading it, because if the leads are wrongly placed, you may end up identifying abnormalities that do not exist. So it is extremely important that we pay attention to the proper placement of the lead. Placement of the lead, even one intercostal space or two intercostal space higher, can give you abnormalities that may not be present. Same thing with the limb leads. Okay, so it is possible for an astute clinician to be able to pick up that the leads have been misplaced, but it is extremely important. This may not be the case for everybody, so it's extremely important that the person performing the ECG. So, in brief, at the fourth intercostal space, left and right parasternum, that's where V1 and V2 are placed. We place V4 at the fifth and the mid clavicular line. Then we place V3 between V2 and V4. Then on the same line as V4, we place V5 and V6 in the anterior axillary and mid axillary line. Now, occasionally we have V7, V8, V9 in order to see the posterior part of the heart, because this part of the heart is usually not captured or represented very well on our standard 12 lead ECG. And so the ECG appears different depending on where the lead is placed. So as I said, each of the leads will record the ECG based on the direction of the signal. So a signal moving towards a lead will produce a positive deflection, and a signal moving away from the lead will produce a negative deflection. And since the heart lies in the precordium, okay, on the left side, you can imagine that the right-sided lead, the AVR, would manifest as only negative deflections, okay? And so if you get positive deflections in AVR, then you have to start, you have to be able to explain why. And so the normal ECG will look different depending on the lead that we're recording it from. So it is possible for us to tell from our ECG which part of the heart is manifesting a certain abnormality. And this is particularly important when it comes to ischemia. Okay, we're able to tell with some degree of certainty that this ischemia is happening on the right, on the inferior wall, on the anterior wall, on the lateral wall, based on the distribution of the leads. And so when you have V1, V2 V1, V2 are so placed that septal electrical activity show very well on these. V4, V3, V4 anterior, V5, V6 are looking at the lateral part of the heart. And then 2, 3, AVF are inferiorly placed leads. And so you do reflect more inferior part of the heart. 1 AVL are lateral. So with this knowledge, we are able to tell with some degree of certainty which part of the heart is suffering, especially when you have this is particularly important when we're dealing with ST segment elevation myocardial infarction. Okay, so Dr. Awindago will I'll let Dr. Awindago, what do you want to say about the heart rate calculation? So we're going to start analyzing the ECG, and Dr. Awindago will start with the various ways in which we can determine the heart rate. So feel free to jump in at any time, Dr.
Okay.
Awindago.
Okay, Dr. Yakubu. So thank you. Hello?
Yes, we can hear you, Dr. Awindago.
Yes. So the calculation of the heart rate is actually based on the ECG paper, and that is what enables us to be able to calculate the heart rate. So there are different ways of doing it, and it's advisable to adapt a system that works for you, and then you can pick it up. So if you look at the ECG paper, you notice that it's been divided into small boxes or squares. Okay, so that is important. It's important to understand them. And then based on that, and then the bigger boxes, you are able to calculate the heart rate. Before you do that, you need to look at a few things. One is the paper speed. That is very important, and that helps you to calculate the heart rate. And the standard should be at 25 millimeters per second. And then you now look at one method is to use the rule of 300, and that is a 10-second rule. So you are dividing the number of 300 by the number of big squares that you count. So on the diagram, you have the first box, which will give you 300. So you divide 300 by 1. There are two big boxes, you divide by 2, and so forth. There are disadvantages and advantages to that. It is easy, very simple to calculate, but sometimes the RR interval might not be regular, so that might not give you an accurate view. Then there is the other method where you use a 6-second rule. So the 6-second rule is for arrhythmias, and then that's if the heart rate is regular. You can use that, and if it's irregular, especially in atrial fibrillation, you can also use that.
Okay.
So you can also use that to calculate. So the rule of 6 is that you calculate the number of QRS complexes in 6 seconds. Okay, so if you look at the big box, so the big box is 0.2 seconds. Okay, so you need to calculate 30 large squares and multiply by 10, and that gives you the heart rate. That's a 6-second rule. Okay, so that is one method that you can use. And you can also use a 10-second rule where you count 50 big boxes and then you multiply by 6. So by far, counting and multiplying by 10 is easier. So 30 big boxes, you count the number of QRS complexes that are within that, and then you multiply by 10, and that gives you the heart rate per minute. So depending on which works for you, you can use that. But usually the rule of 6 is easier for regular rhythms and then irregular rhythms. So you choose one that works well for you, and then you do that. Then there is the what you use, the small boxes. So you count the number of small boxes, that is the 1 millimeter boxes, between the QRS complexes. Okay, and then you divide 1,500 by that. That also gives you the heart rate. So basically, you have three different methods that you can use to calculate the heart rate. So depending on which you are familiar or which is easier for you, you can use that to calculate the heart rate.
Great. Okay, great. Well said, Dr. Windago. So I think I have to emphasize what you also said. So it's always important to look at the speed. Okay, look at the speed, make sure that it's 25 millimeters a second. Thank you very much.
Thank you.
So when we talk of a normal sinus rhythm, we mean we have a P wave preceding each QRS complex. Now, this P wave will be upright in the inferior leads. This tells us that it's coming from up down, okay, from the sinus node, which is above, and then depolarizing. So we have an upright P wave in the inferior leads following a QRS complex. We say we have a normal sinus rhythm. Now we mentioned that the P wave reflects atrial activity. So the morphology of the P wave can give us an idea of what is happening in the atrium. So atrial enlargement. The best leads to analyze your P waves are the lead V1 and then lead 2. It shows very well on most of the inferior leads, but lead 2 is particularly a good lead to analyze your P waves. Now, the first part of your P wave reflects right atrial activity, and the second part reflects left atrial activity. And so often in vein 1, you find that your P wave has a biphasic morphology, where the first part represents right atrial activity and the second part left atrial activity. Okay. Now, when you have enlargement of your atria, you have a deep negative box in vein 1 that is more than one big box, okay, and it's wider, but the width is particularly important, wider than one big box as well. Now, when you come to lead 2, because the second part of the P wave represents left atrial activity, the P waves will appear broad, and occasionally it might be bifid. Okay, the first part represents right atrial, the second broad part representing left atrial activity. And when you have one that is more than 2.5, more than 3 boxes, so that's 120 milliseconds. It may suggest that your left atrium is enlarged. Now, if your right atrium is enlarged, the first part of the P wave will be tall in vein 1, okay, and then it will be very tall and peaked in lead 2, okay. And if this is more than 2.5 boxes, then this suggests that you may have a right atrial enlargement. Dr. Windago, anything that you want to add here? I think for P wave morphology,
not much, but so not much. I think that for the bifid P wave in the lead 2, we always have to remember that sometimes it might not be bifid, but you can have a wide P wave which is greater than the 12. So a lot of us are always looking for the M mitrale. It might not be there. So that is just to reiterate the point. Yeah.
All right, great. So now we look at the PR interval. The PR interval, so there's a time that it takes the electrical activity to depolarize the atrium and then conduct to the left ventricle. Now, often this will be between 3 and 5 small boxes. That's 120 milliseconds to 200 milliseconds. Now, an abnormally short PR interval will suggest a pathway that conducts very fast, as we might find in Wolff-Parkinson-White or pre-excitation syndrome. An abnormally PR interval will suggest some kind of atrioventricular delay or atrioventricular block. Now, when you're analyzing, there are several aspects of the the QRS complex. First of all, the terminology. Okay, so an initial negative deflection. The first negative, if a negative deflection on the QRS complex that's not preceded by initial positive one, it's a Q wave. Okay, the first positive is an R wave. A negative deflection that follows a positive deflection is an S wave. If you have this huge negative deflection, okay, just as negative deflection, we know positive deflection, we call that a QS wave. So the predominant wave will usually be shown by a capital letter, and then the smaller one will be, so when you have a small letter, so when you have a big R, if you have a small, for example, this last one here, we have a RSR, it means that you have a small R. So we said the initial positive one is an R, then an S, a negative that follows a positive is an S, and then a second R that is bigger than the first, so it has a bigger R there with a prime because there's a second R. Okay, so that's generally how the terminology, how we describe the various waves of the QRS complex. Now, the axis tells us the direction in which the heart is predominantly, a summation of the direction in which the heart is predominantly being depolarized. Okay, so we can have a left axis, we can have a right axis, it could be indeterminate. And in the next slide, we'll look at examples of that. Now, usually your QRS complex should be less than 3 boxes, 120 milliseconds. It should be, but mostly it hardly ever exceeds 2.5 boxes. Now, if you start getting a QRS complex that is wider than 3 boxes, then you have to start looking at some form of conduction delay. Okay, either a bundle branch block. Now, Q waves, you might find Q waves in a normal ECG, and they do not necessarily represent pathology. Sometimes Q waves on the lateral leads simply means a reflection of the initial left to right septal depolarization. And so generally, if you have those Q waves that are less than 1 box wide, okay, very narrow Q waves, less than 1 box wide, less than 1 box deep, those are usually non-pathologic. And usually they will be less than a quarter of your size of your R wave. So there are various ways of determining the QRS axis, and the commonest by far is to look at your lead 1 and then your lead AVF. Okay, so if you have a positive deflection lead 1 and a positive deflection in lead AVF, your axis should be somewhere in this range, so minus 30 and plus 90. Okay, that should be considered a normal axis. Now, if it's positive in 1 and AVF, it means that you are falling within this range. It means that the electrical conduction, summation of electrical conduction traveling in that direction. So that would be a normal axis. Now, if it is negative in lead 1 and positive in lead AVF, we are looking at something in this direction, which will be a right axis deviation. Now, if it is, however, positive in lead 1 and negative in AVF, okay, a small proportion of those will lie between this 0 and minus 30. And so if your lead 2 is positive, it might not necessarily be a pathologic left axis deviation. Okay, but anything from minus 30 to minus 90 will be considered a left axis deviation. And then if it is negative in both of them, then you are probably looking at an axis in the indeterminate range. Now, there are more accurate ways of determining the axis to a few degrees. Okay, but that will be for the specialists and cardiology fellows, and we will defer that to unless somebody wants to know. All right. So when you see a wide QRS complex, it could be a manifestation of a bundle branch block. And when we say bundle branch block, recall that we said that impulses traveling from the AV node to the ventricles travel along specialized conduction pathway. Generally, conduction via these pathways are specialized for conduction, so they conduct fast. Conduction via the myocardium is slow. So myocardial to myocardial conduction will manifest as a broad QRS complex, while conduction via depolarization of the ventricles via this specialized pathway will show us a narrow complex. Okay, so when you have a disruption in the conduction down the specialized pathway, okay, you can either have a left bundle branch or a right bundle branch. So in the case of right bundle branch block, your impulses initially will travel down the left ventricle. Because the left ventricular mass constitutes the bulk of the ventricular mass, often the initial part of the QRS complex will appear sharp, okay, and narrow. But the terminal portion, when the impulses are now conducting via myocardium to the right ventricle, will manifest as a broad terminal part of the QRS complex. So often in your chest leads, you may find an RSR prime in vein 1, like that. And then in your lateral leads, you have a broad terminal part of the QRS complex. Now, when you have a left bundle branch block, it means that your impulses will travel down the right bundle to depolarize the right ventricle, and then slowly via the myocardium to myocardial conduction to depolarize the left ventricle, and you're going to have this broad QRS complex. Now, because most of the mass of the ventricle is on the left side, the lateral leads will manifest a positive deflection because the impulses are now moving from left to right. Okay, so you have a tall, broad positive in V5, V6, 1 AVL, and then you have predominant negative deflection in the anterior precordial leads. And often the septal Q wave that you find in the lateral leads will be missing because the impulses are conducting from right to left. You don't have the initial septal depolarization there. Occasionally, you may have not a disruption of conduction of the entire left bundle, but you may just have either the anterior or posterior fascicles being affected. And this will usually manifest as an axis deviation. So an extreme left axis deviation if it's an anterior fascicular block, or an extreme right axis deviation is a posterior fascicular block. So we spoke about pathologic Q waves. If they are deeper than 2 small boxes or they are wider than 1 small box, it's probably pathologic. Okay. Now, normally in the lateral leads, 1, 2, AVL, V5, V6, I mentioned that you may find Q waves that are not pathologic, and these we call them septal Q waves. And usually they will not meet this criteria, and generally they will be less than a quarter of the height of the QRS complex. So, Dr. Windago, there are so many criteria for left ventricular hypertrophy. Okay, I think it's one of the manifestations that can be easily identified on the ECG. Maybe Dr. Windago want to say something about that.
Yes, so that is right. There are quite a lot of criteria for diagnosing left ventricular hypertrophy, and we have the commonest one that a lot of us know about, which is the Sokololion criteria. Though it's quite sensitive, it's not so specific. There are a lot of factors that affect it. You also have others, that is the Cornell criteria, which is also very common. And then one of the very specific ones, the Rumfeld-Estes criteria. But then that is a bit complicated. You need a lot of things, and then you score it. Based on the score, you are more likely to have left ventricular hypertrophy. So the commonest, like I said, is the Sokololion criteria, which we usually use, which would be S wave in B1 plus the R wave in B5 or B6. And if it's more than 35, usually we consider it to be left ventricular hypertrophy. But then that also has age criteria. So for a young person who is less than 40, it moves up to about years. So, and then for someone who's more than 40 years, the 35 strictly applies. Once you get that, it's left ventricular hypertrophy. The other criteria, I think we can look at those ones later.
Yes.
Dr. Yakubu, or
Yeah.
yes.
Yes,
So
I
we
agree.
look at
Yes, yes.
those.
I think that the commonest one, the Sokololon, as you rightly said, the voltage criteria, your S and V1, your R and V5, more than 35. So you also made a point that it lacks sensitivity. Did you say it lacks sensitivity or it's not specific? So,
It's not specific. Yeah. So
all right.
so
Okay.
low sensitivity, low specificity. So
Exactly.
that's for the
Yes.
Sokolo Leon.
Yes.
Yes.
Yes. So it means that we can have patients on echo who will subsequently be diagnosed left ventricular hypertrophy, even though it did not manifest on the ECG. And when we are interpreting, young people tend to have very tall voltages. If you're reading the ECG of young people, sometimes you notice that they may meet voltage criteria for left ventricular hypertrophy. But if you look at this, there are certain non-voltage criteria that sometimes you look at. For example, there are repolarization abnormalities. So if you look at most patients with left ventricular hypertrophy, you look at the ST segments, you have this downsloping ST segment with asymmetric T wave inversion that we call the strain pattern. So all those are subtle clues that this person may actually have left ventricular hypertrophy, even when sometimes they don't specifically meet the voltage criteria. Okay, and sometimes looking at the atrial size can also give you a clue whether this person actually has left ventricular hypertrophy or not. All right, great. Thank you. Now, analysis of the ST segment is also another very important part of ECG reading, because often we diagnose ischemia based on the behavior of the STT segment. Now, for diagnosis STEMI, we measure our ST segment at the J point. The J point is the point where the KRS complex and the ST segment meet. Okay, so the end of the S wave and the beginning of the ST segment. Okay, that's the J point. Okay, so how far deviated your J point is from. Usually in a resting ECG, your TP point and your PR segment will often be in a line, but that is not often the case. So when you are using your TP point, that can be problematic. So it's sometimes recommended that you just compare your J point with your PR segment, and the degree of deviation will give you your ST segment elevation or your ST segment depression. And the criteria for STEMI will be a new ST in the right clinical context. That is also very important. And our ECGs will show that analyzing the ECG in clinical context is very important. So in the right clinical context, a new ST segment elevation at the J point in two contiguous leads, that is more than 2 millimeters per millivolts, okay, in V2, V3, okay, when in men less than 40 years, or 2 millimeters in men more than 40 years, or 1.5 in women, regardless of age, qualifies for STEMI. Okay, now for all other leads, we use 1 millimeter. And if you start reading ECGs, you realize that a V2, V2 often manifests some level of ST segment elevation, which is why the criteria for a much higher voltage in order to improve the specificity. Okay, so all other leads 1 millimeters of ST segment deviation, elevation at the J point. Of course, in the absence of left ventricular hypertrophy or left bundle branch block, because these conditions often cause abnormal deviation of the ST segment, even in the absence of acute ischemia. Now, for the posterior leads, we mentioned V7, V8, V9. The threshold may be lower. We use 0.5 millimeters. But for the standard 12 lead, 1 millimeter in all leads, apart from V2, V3, where the threshold is much higher, depending on gender and depending on age. Now, the nature of the SOST segment deviation helps in our diagnosis, in that often we say that the ST segment elevation in ST segment elevation myocardial infarction is convex upwards. Okay, it may be flat. Okay, but if you compare that with this concave ST segment elevation that you might find in non-ischemic situations such as early repolarization or pericarditis. Okay, so often ST segment elevation, you have the convexity, there's a tendency towards convexity upwards. Now the T wave also behaves similarly. It may have dynamic changes when you have ischemia. This is how the normal T wave looks like. When the base becomes narrow and becomes pointed, okay, so we see the T wave is very pointed, narrow base, pointed T wave. That's typical of hyperkalemia. You can have hyperacute T waves in ischemia, but in these ones, the base tends to be broad compared with what you have in hyperkalemia. And there are various ways that the T waves can also, you can have them biphasic, symmetric with associated ST depression, which may suggest ongoing ischemia, or just symmetric with normal ST segment for previous ischemia. Okay, but as the second segment of this this one will emphasize, clinical information is extremely important when you're analyzing ECG. The QT interval is the interval between the from the beginning of your Q wave to the end of your T wave. Okay, and often we correct it for the rate, because as your heart rate increases, your QT shortens, and then as your heart rate decreases, it prolongs. So we have what we call a corrected QT, and there are various forms. Like the commonest one is the Bazet one, where we divide the QT by the square root of the RR interval in seconds. Okay, an abnormally prolonged QT or abnormally shortened QT can predispose to life-threatening ventricular arrhythmias. And when you look at the ECG and the interval from your beginning of your QRS, QRS to the end of your T is longer than half of your RR interval, then you have to suspect that your QT is probably prolonged, and then you take a closer look at it. So you need to have a systematic way of reading the ECG, and with time it becomes pattern recognition. But reading your ECG systematically ensures that you don't miss important pathology. Okay, you look at all the leads. Okay, you look at the settings, the speed, the amplitude, and then you analyze systematically. So we've talked about the various ways in which you calculate the rates for both regular and irregular rhythms. You look at how your P waves look. This gives you an idea of where they are originating from. Do they look like they're coming from the sinus node, in which case they'll be positive in the inferior leads? Or do they look like they're coming from somewhere else, like another part of the atrium? Then you look at your conduction intervals, your PR interval, is there any PR delay, your KRS complex width, your QT interval. Okay, then look at your axis. Okay, you can be able to tell whether there's any axis deviation. You may even detect lead misplacement based on the axis of your QRS complex. Okay, you analyze your ST segments and then your T waves. So this is how a normal ECG would look like. Okay, but I projected this slide to emphasize the little settings or little writings that we will often ignore. We already spoke about the amplitude, which usually be done at 10 millimeters per millivolt. So this, so usually at the very far left of the ECG, you'll find this marker that will usually cover two big boxes to suggest that it was done at 10 millimeters per millivolt. Okay, then look at your speed to ensure that it was done at 25 millimeters per second. And abnormally high speed, if a speed is double, your QRS complexes will be widely spaced, and you may end up diagnosing with bradycardia if you don't look at it very well. Same thing is if the speed is halved at 12.5. And there are various instances when this may be useful. Okay, but generally, you should make sure that your speed is at 25 millimeters per second. Then a few other ones that we often don't look at, what we call the filter settings. So you find a frequency here 0.05 to 150, okay, which is often the standard setting on most ECGs. Now, this is supposed to filter out artifacts in order to give us a clean reading. Okay, so the 0.05 lower point is what we call the high pass filter. In other words, voltages or frequencies that are above 0.05 will be allowed to pass through. Anything below that will be filtered out. And this is very important, especially when it comes to respiratory movement, filtering out respiratory movement. Respiratory movement can give you an undulating baseline. And so presence of this filter filters out these low frequency waves in order to give you a clean baseline. Now, same thing with the high frequency, the low pass filter, which is 150 hertz there, which means that frequencies below that will be allowed through, and frequencies above that, like myopotentials, muscle twitching, AC current, will be filtered out in order to give you a smooth baseline. Generally, you want to ensure that you do your ECG. Make sure make sure the leads are well positioned. You do not want to filter. Tampering with the filter settings should be a last resort, because there are implications to tampering with the filter settings. For example, if you increase the low pass filter in order to smoothen the baseline, you risk missing out or misdiagnosing or creating artifacts in the ST segment portion of the ECG. Same thing with the high pass filter, lowering it in order to eliminate high frequency can have implication on ECG diagnostic criteria that require voltage. Okay, so you might miss out on ventricular hypertrophy or other criteria that are relying on the voltage. So generally, you don't want to be tampering with the filter settings. You want to obtain a clean ECG by ensure a thorough skin preparation, eliminating any interfering electromagnetic waves or currents, and as much as possible, if you are getting electrical artifacts, especially this can be common if you are running a generator. If you can print the ECG using the battery in it, that may filter out, that may ensure that you have a smooth ECG. So tampering with the filter settings of your ECG should be a last resort. So this will be the last slide of our basic overview before we go into to look at some ECGs and then invite questions. Dr. Windago, will you have anything? Dr. Samoa, do we have questions at this stage that we can address, or can we delve deep into the second part?
Yes, so Dr. Yakubu, there are no questions at the moment, so you can go ahead with the second part of it, and probably questions may come up over there.
All right, great.
So I also wanted to add, in terms of the filtering, electronic devices. So sometimes some patients still have their phones on them, and that can also interfere with the ECG baseline. And rightly, you mentioned the generator bit of it. So we just need to troubleshoot again and again to make sure we get a very clean ECG.
Yes, thank you very much. Okay, so the tampering with the filter settings to get a smooth ECG should be one of last resort, because when you do that, you compromise the diagnostic capability of the wider it is, the more likely you are to get picked up. But sometimes leaving it very wide to exposes your ECG to a lot of artifacts. All right, so we're going to be looking at some ECGs. We invite questions and comments in the comment box about the ECG as we go on. All right. So our first ECG is that of a 52-year-old with palpitations. So because I mentioned that we need to read ECGs systematically, okay? With this part of the ECG, we're just going to be looking at the pathologies in the ECG, but if there are any comments on anything that we might have missed, then we can go back and look at them very systematically, okay? All right. So, Dr. Widago, this person, 52-year-old woman with palpitations, what is obvious to me is that I see that the ECG looks a bit irregular. Okay, so that catches my eye immediately. So I look at this ECG and I see that there are some irregularity. Okay, but most parts of it are regular, and I see occasionally irregularities as well. Okay, then I see some. If you come to vein 1, you see a lot of positive deflections there. Okay, they are regular and they are at a rate of about 300. Okay. And then when you go to V2, you find some negative deflections there. So I think I have my diagnosis in mind. Dr. Widago, what do you think?
I also think so. Yes.
Our audience, anybody who wants to type out the diagnosis? Asamoah?
Yes, Dr. Yakubu. So I haven't seen any
anything?
contributions.
Okay.
No, but participants,
Okay.
please feel free to post your contributions in the comments, and so that we see.
Okay. So the important parts of this ECG is these waves that I think Awidago will agree with me that they are flatter waves. Dr. Awidago, what do you think? They are positive in lead
Yes,
V1.
I agree with you.
They are negative in lead 2.
Yes.
Okay.
2, and then
yes.
And also negative in lead 3, and then in AVF. Yes.
Yes. And this seems to suggest that the morphology is very typical of a flutter that is occurring at a certain part of the heart. What do you think about that?
Yes, if you look at it, the flutter waves are quite regular. They are quite similar. So for the flutter waves, they are very regular, and that could be coming from the what we call the around the Cox triangle. So the tricuspid, the annulus of the tricuspid valve.
Okay, good. Good. Dr. Samoah, there was a. Can we proceed from here? So Dr. Awidago agrees with me that this is looks like a typical counterclockwise flutter with variable block.
Yes, precisely so. And however, I still don't see any comments from any of the participants. So I believe we can go on.
We can go on to the next one. All right. So I'll leave the next one. Dr. Widago will look at the next one. So Widago, this 50-year-old female diabetic comes with abdominal pain.
So 50-year-old diabetic female with abdominal pain. Okay, so looking at this ECG, straight away I see that it looks like it's a slow heart rate that I can see. That is one. And then we now look at the other obvious abnormalities that I can see. But then I'll look at the P waves, which I think I can see some P waves, V1. Yes.
Yeah, I can see. I can see. What I am not sure about is whether they are related or there's some kind of.
They seem not to be related. Looks like you have some of them buried within the QRS complexes. If you look at the complex that's at V1, No, there's one just before the QRS complex.
Yes, yes. And then it seemed to match through the QRS complexes, isn't it? As if they are doing their own thing. Sorry, Dr. Samuel, can you hear me? I can't hear Dr. Windago.
Yes, I can hear you. I think
Okay.
yes, I also can't hear Dr. Windago. I think he's having a few network issues, but he's sorting it out. But I can hear you.
Okay. All right. So Dr. Windago picked up that the T wave, the P waves seem to be behaving independent of the QRS comment. That may suggest some kind of AV delay as well. Asamo, what do you think about the ST segments? I think there may be a relation between this person's pain and what is happening on the ECG.
Yes. So with the ST segments, looking at leads 2, 3, and AVF, which are the inferior leads, they look significantly elevated. I think it's about 4 or 5 small boxes above the PR segment.
Yes.
And then when you look in leads 1, AVL, and then Z1 and Z2, see some ST segment depressions. Yes, so these are what I think about the ST segment.
Okay. So is Dr. Windago back? So this
Yeah, so I'm back. Yeah.
Yes. So I agree with Dr. Samuel that the ST segments in the inferior leads may suggest STEMI. But then when I look at the lateral, look at V6, you may see a suggestion of ST segment elevation there. And so this is a patient that I probably would want to do V7, V8, V9 for. There's a chance that this may not be just an inferior, but it may actually be an inferior posterior segment MI. And those key waves in the lateral leads may actually be part of an older MI or may be part of this current MI. So we may actually be dealing with an inferior posterolateral MI here with associated conduction abnormality. And then I'm not surprised that a diabetic may not manifest chest pain, but may have epigastric pain. And it is not, I've seen several of these patients that have been treated for peptic ulcer disease, just later to be diagnosed with a STEMI. Right. So we go to the next ECG. So this is the ECG of an alcoholic who was involved in an RTA, and then I think this was part of a pre-op assessment. What do you think, Dr. Felix Windago? My impression about the baseline is that it's extremely. I'll start off by saying that whilst this may look very on the first impression, it may look as if it's irregular, but if you actually do your mapping out, it looks like a regular, and we may just be dealing with baseline artifacts. And it is extremely important to look at all the leads, because if you look at V2, you can actually map out P waves, okay, just after
exactly.
with what looks like a prolonged PR.
Yes.
Okay, so I think this is extremely important when you're looking at your 12 lead ECG. Look at all the leads. That's why you have 12 leads. Okay, so the P wave may not be apparent because of some baseline artifacts. And if he's an alcoholic, well, maybe he's getting tremors. We don't know. Felix, what else? You have a comment here?
Yes, so I tend to agree with you. Yes, you can see the P waves in lead 2 clearly. The other striking thing is that the QRS complexes are quite broad.
Yeah.
And yes, so you also notice that in V1 is more of a, there's more like an S straight away, so it's a deep S from V1, and then as you go to V6, it becomes positive, still broad, with a slurring of the S wave in V6. Another striking feature is the T waves that seem to appear hyperacute. But again, we need to look at the context of the deep S waves that we are seeing, the QS waves we are seeing.
Okay.
Yes.
Yeah. So I think those are extremely vital information in there. And so when I combine these tall T waves there with a prolonged PR interval and barely perceptible P waves, I'll probably be very interested in this patient's potassium as well. I'll be very interested in the context of a widened QRS complex. I'll be looking very closely at this patient's potassium. Okay, I'll be expecting hyperkalemia in there.
Dr. Afubu.
Hello.
Yes, so a comment just came through. I think it's for the previous ECG.
Okay.
And this is from Daniel Afubu, who is saying that he thinks it's a third-degree AV block with ST segment elevations in the inferior leads and ST depressions in V1 and V2. So that's from Dr. Amokibobi.
Yes, I agree with Dr. Bobby that there seems to be some AV dissociation in the context of an inferior ST MI. There are the chance that this patient may not end up with a permanent pacemaker, and that this AV conduction abnormality might correct with correction of the ischemia. Okay, if anything at all, he may need a temporary pacing if the rate is a problem. But in the context of an inferior MI, and we know that the supply of the AV node comes from the PL branch of the RCA, we will expect this. There's a chance that this AV conduction may not be permanent, and this patient may not end up with a permanent pacemaker. Great. Now, a 47-year-old man with a history of ischemic heart disease. Dr. Widago, when I see an ECG like this in somebody with this history, one diagnosis comes to mind until you convince me otherwise.
VT.
Exactly. So Dr. Widago, any who want to explain to us why?
So because of the history of ischemic heart disease, you need to think about the possibility of scar formation, which could lead to which can be a needles for formation of a VT. So with something like this, that's the first thing I need to think about before I begin evaluating. If the patient is unstable, then we might probably start managing as VT until proven otherwise. But then we need to look at specific features and see if this meets the criteria of a VT. Sure.
Yeah. So I think history is key. Okay. A case like this in this clinical setting will be managed as a ventricular tachycardia until ruled out. Okay. Until otherwise. Okay. And they are very what we have here is a broad complex tachycardia which is fast. Okay, there are a lot of criteria that we find in our book, the Brugada criteria, Vericay criteria, which we can all go and read. Okay, but often we may not find all of them. Okay, so if it looks like it, I mean, I just look at V6 and I see negative deflections, and I see AVR and I see positive deflection. That's a very weird axis. Okay. Very weird axis, broad complex in the right setting. We can scrutinize it later for AV dissociation and those other criteria. But in this clinical context, I think a VT until proven otherwise would be the right diagnosis. But this is a ventricular tachycardia. I agree with you, Dr. Windago. So we see another ECG here. Dr. Samuel, can we continue? Are there any comments, clarification that we need to make? Otherwise, we'll look at the next one.
So Luke Mankinan just commented on the previous ECG we just finished, and he's saying he thinks it's a left aspiration and a ventricular tachycardia, which we've agreed on.
All right.
Yes.
Okay. Great. Look.
So that's the last comment that has come. So you can go ahead.
Okay. So Dr. Windago, maybe can take this one.
Okay. So this is 60-year-old male smoker with exertional dyspnea. 60-year-old smoker with exertional dyspnea. So, okay, so look at the, if we go systematic, the rhythm straight away doesn't look regular. It's an irregular rhythm.
Yeah.
Then we can count the rate, and then we look at the P waves, and if I look at the rhythm strip, straight away I realize the P waves are of different morphologies. So from the first QRS is a very tall P wave. The second one seems to be a smaller amplitude, which is bifid. The third one also a smaller amplitude, but quite narrow. And then the third one, and again the QRSs are irregular. Heart rate, I believe, will be more than 100 beats per minute if I look at it. So yes, and look at the history too. Most likely the patient has COPD and has a multifocal atrial tachycardia.
Great. So I agree with you 100% on this one. If you
look at the, I think the QRS also gives us an idea of left ventricular hypertrophy.
Yes, and then in V1 we seem to have more positive than negative. So there may be some right ventricular hypertrophy there as well. Look at V1. RS ratio is more than 1 in V1. And then you have a right axis deviation as well. So,
and then V6 too, we have a persistent S.
Exactly.
Wave, which seems to be more than the R wave in V6 and V5.
Great. So they just fix the picture of a COPD with multifocal atrial tachycardia. There's evidence of a right ventricular hypertrophy and as well right axis deviation. Great.
Dr. Akubu, if I can just chip in briefly. So there are instances where there may appear to be some differences in the PA that may not be too clear. So I think another thing that we can do is to also look at the PR intervals between these various PAs and the QRSs. Usually, if it is truly multifocal, meaning the impulse is coming from different places, the PR intervals will vary. But if the PR intervals are equal throughout, then chances are that it is not actually a different morphology PA, but probably just some artifact-related thing that's going on. So that's all I wanted to chip in. Thank you.
Yes, right. But the morphology is extremely important. So yes. So often when you have impulses from different parts of the atrium, they may be, because of the time it takes to conduct from that point to the AV node, there may be slight variation in the PR interval because these impulses are coming from different points which are located differently relative to the location of the AV node. But often don't expect dramatic PR interval changes because these are like a few milliseconds. And so it won't be like a PR interval that is varying from 120 to 2, and not that kind of variation. But the morphology, changing morphology, gives it away. Great. "30-year-old episodic palpitations." I think we can skip this one, Dr. Widago. What do you think? Is there anybody who died with
it seems straightforward.
Yes. There are very few. It is extremely irregular. Okay, when you see an irregular complex ECG, irregular ECG like this, I think often vein 1 shows these waves. Okay, so you can be fooled by you can look too hard and see what looks like P waves in vein 1. Okay, but these are not organized. If you look at them, they change in size. So, there are sections where you don't find any, then you find some. They're extremely small. So these are fibrillary waves, and don't be fooled. These are not multiple PACs. This is atrial fibrillation.
Dr. Kubu, I want to ask a question that is frequently asked by lots of people. So when you look at this ECG, when you look in the V1, someone may think that there are flutter waves over there, and therefore there will be a confusion as to whether this is an atrial fibrillation or it's an atrial flutter with a variable block. In case there are people who have this question listening in, how would you help to clarify what the actual diagnosis of this ECG is, whether it's a flutter or it's an atrial fibrillation?
Yes. So that is quite and it's actually easier in this instance. Some are not so easy, and we know that sometimes people can move from flutter to fibrillation. Okay, but if you look at the previous case that will have a flutter, they'll all look the same. Okay, so when you start having variations in size, and if you look very carefully at some of them, the interval between them is so short that the rate will be somewhere in the range of 400 to 500. We know that most flutter waves about 300. So flutter waves, they usually look the same. So when you start seeing that they vary in size and your rhythm is irregular, it's atrial fibrillation. But it is not uncommon to have people move from fibrillation to flutter at times. And it can be difficult in other situations. But you find irregular, you see that the waves don't look exactly the same. Chances are it is fibrillation. And sometimes that discussion is academic because you end up treating them similar in a way.
Thank you. And we still don't have any comments, so we can go ahead.
All right, great. So this patient was admitted overnight for a medical procedure. Okay. So apparently this is an asymptomatic patient, and this ECG was taken. Okay. So we need to look very hard. We need to look very hard to be able to identify what the problem is. But I put this slide here just to illustrate the point that not every AV dissociation is AV block. Okay, so you can have AV dissociation as a result of AV block, but you can have AV dissociations that may not necessarily be due to AV block. Okay. Do we have any comments on this ECG before we proceed?
No, there are no comments in there. There are no comments.
All right, great. So if you look at lead 2 down here, you will see that Felix, will you want to say something here, or should continue?
Yes, so when I look at it, quite looks a bit bizarre looking at the P waves. Um, so the first in lead two, there's a P wave, but then the PR interval is quite short. And then if I look at the second QRS, I don't really pick a P wave there.
Yeah, it
But
seems
then
to be
the
buried
third,
inside.
exactly. Then the
Yeah,
third one, there's a P wave, but then the PR interval is now clear here. And the
yeah.
next one is also very close to the QRS complex. Looks like a very short um,
Mm,
PR interval.
yeah. So you're having P waves and then the QRS complexes that seem to be at a similar rate, but they don't seem to be related. Occasionally, they just match to each other, but the rate is quite similar. So this will qualify for what we call the isorhythmic dissociation. So you have a atrial and ventricular activity that are occurring at a similar rate. Okay. Uh, it is AV dissociation, but it is not because of an AV block. Because by definition, an AV block, your atrial rate will be higher than the ventricular rate, and you have P waves that have been given enough time to conduct, but they don't conduct. Okay. In this case, you just have two rhythms that are very similar, and then closely related, but it's not as a result of AV block. So we call it an isorhythmic dissociation. And at very slow heart rates, sleeping patients, it is not uncommon that you find this kind of sinus bradycardia with uh, a junctional escape that will occur at a similar rate. But when they are weak, they should disappear. Any comments? We could go to the next one. I think we have a few slides to finish this session.
Um, No, there are no comments, so we can go ahead.
All right. Okay. Dr. Samuel, maybe you can look at this. So this patient is a male patient. I think they did an ECG for just pre-participation spots, so it's asymptomatic, and then we found this.
All right. So looking at this ECG, if we're to take it systematically, first of all, we have a rate which is about 100 beats per minute. Um, we have a P wave before every QRS complex, upright in the inferior leads, and of the same morphology, such as a sinus rhythm. The PR interval is fine. I mean, it's normal. The QRS complexes all seem to have a normal morphology. Amplitude looks okay, the duration looks okay. Now, with the ST segment in lead 2, 3, V6, V5, there's a bit of an ST depression. Not so impressive, but there is some ST depression. But most importantly, in V1 and V2, there's some degree of ST segment elevation with T-wave inversions.
Yeah.
And actually, this pattern of ST elevation in V1 and V2 is called coving. So it's a coved ST segment elevation.
Mm,
And once you see this, it is pathognomonic for a patient with Brugada syndrome.
okay. Yeah. So this, I agree with you that this is a Brugada pattern ECG, type 1 Brugada pattern. Um, so if this patient has never had symptoms in the past, hasn't got high risk features. So the problem with Brugada is that they're at risk of ventricular arrhythmias. So you want to risk profile people like this and very high risk patients who've had sudden cardiac arrest or ventricular tachyarrhythmias will probably benefit from secondary prevention ICD. Otherwise, for this patient who is asymptomatic, you probably want to make sure that they avoid triggers. Something as simple as a fever can trigger their arrhythmias, avoid alcohol, electrolyte abnormalities, and a lot of sodium channel blockers. So for this patient who is probably has no, if he has no family history, has no previous event history of sudden cardiac arrest, this will qualify for a low risk, and you may do conservative after a thorough shared decision making. So it does look like a pseudo, some kind of right bundle branch block, isn't it? But this is not a typical right bundle block. The morphology in V1, V2 give it away. So I agree with you, Dr. Samuel there. 50-year-old hypertensive with dyspnea. I think we can skip this one. Are we done? What do you think?
Yeah, I think we can skip.
Yes. So you find very impressive ST segment elevations there, but if you look at the degree of your S waves in those ones, you know that those ST segment elevations are probably related to the left ventricular hypertrophy. But so the bioclinical pictures all important. So LVH, probably hypertensive heart disease, but you can't always this pattern of ST segment elevations probably as a result of the LVH rather than ischemia. So we put this slide in there just to demonstrate. I think that we had another slide with very impressive tall P waves there, tall pointed P waves there. So just to illustrate how right ventricular hypertrophy looked at. Notice how narrow they are, okay, and they are tall. So these are right ventricular, right atrial enlargement, okay, tall pointed right atrial enlargement, and then there's probably right ventricular enlargement with out as well. So a 30-year-old female who suddenly became dyspneic postpartum, okay. What is obvious? Yes.
Yeah, so someone wants to know in the previous example with the LV hypertrophy, I think 2 ECGs before this, and the person wants to know why the ST segment changes are more likely to be due to the LVH rather than being suggestive of ischemia.
Okay, so we cannot be 100% certain. Okay, we can't be 100% certain, but concave, kind of high takeoff. You know, it just blends into the T wave, and then the degree. You always look at the S wave. Okay, so if you did the ratio of the ST segment to the S wave, if you look at the literature, you find some formula like that. The degree of ST, so this ST segment is probably proportionate to the degree of your S wave down here. But as I said, you can even have non-STEMIs that are non-STEMI in these people. So it doesn't mean that person doesn't have coronary artery disease or hasn't got a MI or anything, but the picture is extremely suspicious for secondary polarization abnormality. I think that's just the point you want to make. If you compare the other ST segments that we have shown, and then the nature of this ST segment elevation, but often it's never say never, but the concave nature, the way it blends into the T wave, and then the degree of the S wave in those leads. You can even see the end of the F wave, they overlap. Okay, so it's probably proportionate to the degree of the S wave, and it's most likely repolarization abnormality. But every now and then you get surprised. Okay, so this For somebody who suddenly becomes dyspnea postpartum, Dr. Widago, what do you think? I
Yes,
look at this
so
ECG and then diagnosis is screaming at me.
yeah, so the first thing you would notice is that there's some sinus tachycardia, and looking at the history, what I would think initially is so let me go through the process. So P waves. So look at the P waves. Looks sinus, so more like a sinus tachycardia, and then I look at the lead one, and what I see is that there's a prominent S wave there, and then though you don't get a typical pattern, you look at lead 3. You find some P waves, but they don't look that pathologic in some of the leads.
Yeah.
Then you move to V1, V2. You tend to have these T wave inversions,
Yeah.
and then that seems like some strain those areas, and then persistent S waves in V5 and V6. So more like some right ventricular strain pattern. So with a history, I'll think of a P first.
Yeah.
That's a differential.
Yeah. So I think this patient had a P eventually, CTPA confirmed a pulmonary embolism. Yeah, was managed conservatively. She did well. Okay. Now, in this particular ECG, this 62-year-old woman has recurrent syncope. Okay, so you find a baseline that you can hardly identify P waves, and then you have regular QRS complexes. Okay, if you come to V1, maybe you find that your baseline is a bit irregular. Okay, so you can have atrial fibrillation and have a regular rhythm. Okay, so those are the instances when you can have atrial fibrillation, but still your rhythm can be regular. In this case, regular and slow because of a complete heart block. Okay, so this is a complete heart block with atrial fibrillation, and we need to put in a pacemaker there. Uh, what kind of pacemaker do you think may I get, Dr. Windago?
But that's one complete heart block. So you need a D. So
Yeah,
a biventricular um, pacemaker. So you pace the atria, pace the ventricles, and then you sense.
but let's say this is permanent atrial fibrillation. If it's permanent atrial fibrillation,
So you won't sense the atria. So you not sense the atria because when you do that, it would so the pacemaker would identify the atrial fibrillation as would sense, and then
yeah,
probably would act. So you won't pace the atria.
yeah, yeah. So this is probably one of the few instances when we just put in a VVI, okay, so that it just avoid the atrium because it's a permanent atrial fibrillation. You can't sense that, pace that. So one of the few indications for a VVI, but most people will get a dual chamber as we do. Okay, great. Cardiac arrest in a 60-year-old male. Dr. Samoa, you want to comment on this ECG?
Yes. So
This has a certain pattern, isn't it? The nature of the
yes.
process, yes.
So I'll just focus on so this one, everything looks like it's a rhythm strip, right? As in
Yes,
each,
so exactly. I
yes,
think they are all rhythm strips. Yes.
yes. So when you look at the second half of each of these ECG strips, you realize that first you have some bizarre Y complexes, and then they tend to get shorter and shorter towards the middle. Then they remain that way. Then towards the end, they start to get taller again. And So you would be able to tell that this is actually a type of ventricular tachycardia because it has that morphology. But this particular one, once you see it, is pathognomonic for what we call torsade de pointe, which is a type of polymorphic ventricular tachycardia. Thank you.
Okay. Yeah. So the torsade is a polymorphic ventricular tachycardia that's associated with a QT prolongation, and I think it's exactly as you have said it. I think when I took this slide, there was a caveat in there that the patient had received ciprofloxacin for a UTI, which is significant because that's a QT prolonging drug. And if you look at the ECG itself, you realize that this person probably was having ischemia as well, isn't it? Because you look at some of the leads, there you see some ST elevations as well. So probably ongoing ischemia, maybe electrolyte imbalance, some other procedure, the person goes into TOSA. All right. Dr. Widago, can we continue? I think, do you want to make a comment here?
Yes, I think we can continue. Yes, I think we can continue.
Okay. So this is a much younger patient who has palpitations, very fast heart rate. Okay. Very fast heart rate, narrow complex. Okay. You can hardly see P waves. You may see what looks like P waves, but they may be the T waves of the previous one. But if you look very carefully, which unfortunately this is a very bad ECG, but this is supposed to be a patient with a SVT, okay, AVNRT. Often you will not see the P waves because they are buried in the KRS complexes. Sometimes you may see pseudo Q or pseudo S. Let's continue.
The previous one, if you enlarge it a bit, magnify it, you'll be able to see.
Yes, you can make them out, isn't it? Yes,
you can make them out just after the QRS. You see these bumps.
Yeah, you see a bump on V1 and then you see a bump after V2.
Yeah,
those are supposed to be pseudo Q and pseudo R, typical of a AVNRT. Okay, this was just to show impressive ST elevations, but we've looked at a similar case. ST. There's one that I want us to conclude with. There was an issue. Okay, this one. Doctors, Awindago. Let's. Do we have any? Our participants are not able to speak, isn't it?
No, they're not able to speak. They can type in the comment box, but they are not able to speak.
They are not able to speak. All right. So this is the ECG of a female with palpitations. Okay. So we look at the ECG and you find intermittent broad complex. So I mean, these are what we call a premature ventricular complexes. Okay. So the next question that maybe we may ask will be, where are they coming from? Okay, Dr. Windago, what do you think?
Not sure where they are coming from, but let's see. So if we look at the pattern from V1, it's looking like a right bundle branch block pattern.
Okay.
But then when you go to V6, you still have
that.
So it's looking like, yeah, exactly. So it's funny, difficult to tell. But if it's coming from somewhere in the septum, it could give you this appearance. But that's difficult to tell.
Yeah. But let's look at it.
But then if I look at the rhythm strip, Yes.
Yes, please go ahead.
Yes, so if I look at the rhythm strip, I'm trying to see if I can see P waves that much. But then if you look at lead 3, I'm not sure if it's a P wave just before the QRS. There's what looks like a P wave there. So let's go. So the first QRS looks a bit bizarre. And then you have one that looks like a normal QRS. That is the second QRS complex.
Yeah.
And then there is what looks like a T wave. And then just before the QRS, I'm not sure if it's a P, but then you have this QRS PVC. And then exactly. And then when you look at it, a normal QRS, then a PVC, a PVC. So
So this person has a very large PVC burden. Okay, very large
yeah,
PVC burden. So, but we can use the axis to help us determine where it is coming from. So if you look at lead 2, lead 3, even F, you can see that those leads are positive, isn't it? So if lead 2, 3, even F looks positive, okay, so mean that it will look as the impulses are coming down, okay, from up down. Okay, so we have an idea of where it is coming from, up down. Okay, but how up? Okay, so then we go and look at AVR and AVL. Okay, let's go to AVR.
AVL,
AVR is
AVR,
predominantly
they are looking down.
down. Okay, so
They are
AVR,
down.
AVL
Yes.
are negative. 2,
Yeah.
3 AVF positive. Okay, so it's coming
Positive.
from high
So
up, moving away from AVL, moving away from AVR, coming towards
AV,
2, 3 AVF. Okay, and then as you rightly said, V1 has that kind of a positive, isn't it? Maybe
yes.
that may look like a right bundle, but also very important,
Yeah.
we call something transition. Okay, it becomes very positive early. So it gets, even as V1, V2 is predominantly positive. Okay, so this is most likely something that's coming from the left ventricular outflow tract. Okay, so LV, if it was right ventricular outflow tract, it looks similar, but the transition tends to be later, the transition around V4, and that will be more looking a lot more left bundle. All right, so I think this is probably for Dr. Awindago and I, our audience. I hope you followed us. So this is our last slide. Do you have any comments on that? Then can continue, Dr. Samoa.
No, there are no comments over here.
All right,
So
good.
we can go ahead with the
All right.
last
So
one.
this is our last slide. Okay, this is the last slide, and I put in there's no history, and I say history is important. Okay, so often when we are sending out ECGs for comment, it's important that if we add some history, we get uh, a better comment and probably good suggestions. Okay, so we often try as much as possible to read ECGs in the context of a history, and the history will probably help us give better comments. Okay, so we should insist on that and try to give as much history as possible. So if this person was a 30-year-old asymptomatic footballer, we may think different, isn't it? We may say hypertrophic cardiomyopathy. And then if I told you that this is a 50-year-old diabetic with chest pain, then we'll say ischemia. And then if I told you that it's a hypertensive poor BP control with hemorrhagic stroke, then we'll say these T waves are probably due to raised intracranial pressure. So history is very important. Okay, and so this will be my concluding remarks. Dr. Widago, over to you. Anything you want to add?
No, not much. Thank you. And I think it's been a very fruitful session. I've learned a lot, and I'm sure our colleagues listening have also learned a lot. So thank you. I'll hand over to Dr.
You
Samuel.
too, Dr. Samuel. Yeah.
All right. So thank you, Dr. Yakubu and Arindalgo, for taking us through first the basics of the ECG, what the waves stand for, and then looking at some of the scenarios, going through some ECGs and integrating them, some step by step to arrive at the diagnosis, and some to help recognize more pathognomonic patterns. And I believe that it's been beneficial for those who've joined in. I still don't see any comments, so I am. If there are any questions, please have them in the comments box so that we can address them. But at the moment, I don't see any comments. Maybe we can wait a minute or so, see if any will come up. If not, then we conclude the session. So if you're okay, we can wait for just about a minute and see if any comments will pop up.
Okay, sure. 1 minute. Yeah.
All right. So all right, there are still no comments. So I think we can end the session here. Oh, I need to don't worry. So thank you very much to all those who joined. And I hope that we've all learned if one or two beneficial things that will improve our reading of ECGs. The thing about ECGs is that it's very volatile, so it's important that you continually refresh what you've learned by reading more about it, and most importantly, practicing on ECGs and seeking clarification as and when necessary. So thank you very much, and have a wonderful evening. Thank you.